and how to avoid it.
Thank you, Kamal. We'll spend the next 20 minutes talking about neurologic complications. We know now in 2011 we have more powerful ways to correct deformity, more aggressive surgical techniques, including osteotomies, more complex legal climate, and the expectations of patients, society, our governments, payers is much higher than it was 10 years ago. So the goal of this presentation is to prevent even one complication. We're focusing on neurologic complications. The United States Institute of Medicine reports, now there have been several, are saying there are too many medical and surgical errors, and there's a huge focus, I think, in all of our countries to push this down, or trying to get to zero is the terminology. The treatment considerations, we all have different training and experience and techniques. The approaches influence this. I think the big change in the last 5 years has been the rapid acceptance of osteotomies, usually Ponte osteotomies in the deformity setting, but other more aggressive osteotomies we'll talk about. And the implants now are pedicle screws, and so things have changed quite a bit as far as insertion and avoiding complications. My practice, I do all pediatric orthopedic surgery. Half of my practice is spine, half is tumor, and the spine half they're atypical cases that are at fairly high risk. So I've been very interested in this topic now for several years, and we're all doing these aggressive surgeries where we take a deformity shown in the lower left, and with destabilization of the spine, multiple osteotomies and coupled derotation, very forceful, aggressive, manipulative maneuvers, we're able to get this type of result. And the structures that are at risk, everyone knows, in addition to the neural elements, we have the great vessels, the lung. We all know the different techniques of pedicle screw insertion, the different orientation based on the location of the spine. The starting points help you understand how to stay away from the canal. But when you look at the complications or the malposition screw rates, even in the best of hands, this is Professor Sook's data, and this is early on, of course, but in his practice, 1.5% of screws were malplaced. Here's another series showing 18% or 18 misplaced screws in this series for a 1.7%. 5 returned to the OR for screw removal. That was several years ago. Larry Lenke, who in North America probably was one of the earliest to begin using pedicle screws on a routine basis, their early publication, 10.5% showed a wall violation. So again, even in the best of hands, this happens. And we've all seen x-rays like this where screws are misplaced. There are case reports and small series of major complications such as aortic perforation presenting 1 year after surgery. Here's another aortic injury, delayed presentation. They're usually delayed. Here's a summary of different reports, condensed, multiple different complications, and for time's sake, we don't have time to really get into this. And I suspect that these are really the tip of the iceberg. Many of these we hear about are not reported. So, and other things such as intracranial hypotension associated with CSF leak and a malplaced screw. Pneumothorax can occur with this. And we all know there's a learning curve. As we do more and more of these, we get better and better. And for the younger surgeons in the audience, the residents in particular, begin in a cadaver lab, get very comfortable with this technique in a cadaver lab before, or work with a senior surgeon. There are different definitions for what is acceptable and what isn't. We know that a hook in the canal occupies a certain percentage of the canal, and a screw certainly sometimes will be in the canal, but maybe less than what a hook would at that same level. So what is acceptable and what isn't is a subject of debate to some degree. And here's another outcome classification showing percentage of screws that are acceptable or unacceptable. But again, this 1.5% number is probably real. One of the advancing new technology is the use of this O-arm for assessment and placement of screws. We purchased our first O-arm about 6-7 years ago. We now have a second. We use it predominantly for spine surgery, but also for other types of orthopedic work as shown in this slide. There are two ways to use the O-arm. The first is where we place all the screws freehand and then bring the O-arm in, scan the patient, it takes about 15 minutes, and then assess the screws and change those that are malplaced. The second technique is to use this as a real-time image navigation live tool. We're studying this, and we have a manuscript that's ready to submit. And the basic bottom line from that research is that there's the two ways to do it. It does prevent unplanned return to the ORs. We had no unplanned return to the ORs for removal. No neurologic deficits, with the exception of one that had a transcranial motor evoked change with the screw placement. That screw was removed. The signals returned to normal. But this technique gives you a certain peace of mind. In my hands, I place all the screws freehand with the fluoroscopy unit in the lateral plane, and then once all of the screws are in, I bring the O-arm in, and usually with one or two spins, I can assess all of those screws. It takes about 15 minutes. In my hand, a third of the cases, I change no screws. A third, I'll change one screw, and in the remaining third of cases, I'll change two or more screws. The real-time navigation technique is a great teaching tool for those of you working at academic centers. This is a wonderful way for your residents and fellows to get experience with screw placement. But this is an expensive machine. It costs around $1 million when all is said and done for the hardware and the software. And this is just a case. Here's a high-risk case. This patient has thoracic or lower thoracic kyphosis, a short, sharp deformity. Here's the MRI. Here's the post-operative. This is a recent case of mine, but this just kind of shows you with titanium the quality of the images that you can see with the O-arm, assessing those screws. You know exactly where they are. There's very little scatter, less scatter with titanium as compared with stainless steel, but you pretty much know exactly where those screws are, and you can get both axial and coronal and sagittal images looking at the screw placement. So much better images with titanium as opposed to stainless steel. We are concerned about the amount of radiation. This is not insignificant. The amount of O-arm radiation averages about 15 milligray, or 20. It equals or is equivalent to 20 seconds of axial fluoro time, and comparable to a lateral thoracic spine X-ray. So what does the future hold? I think 20 years from now, 30 years from now, we're going to be using image-guided surgery much, much more than we do now. There's a cost-to-benefit ratio, a risk-to-benefit ratio, certainly. And we have to remember the amount of radiation, especially that these young children get. Is the benefit outweighed by the cost or the risk? Coupled derotation. I think most. How many of you in the audience are using coupled derotation for your deformity case, where you link the screws together and you're pushing two sets of screws against each other for very aggressive derotation? And the concern is that one or more of those screws will cut out and injure the spinal cord or other structures. But I believe that this is a safer technique because there's strength in numbers. The screws are coupled, and you can not only get major corrections, but you can also use this as a safety tool to prevent a case from a single screw from cutting out. So here's the case. Here's the bending films. With this aggressive coupled derotation, you can often get these curves down to zero, and occasionally even go the other way. So you have to be careful not to overcorrect. The importance of monitoring carefully and having sophisticated monitoring is especially important in the spine tumor realm, where you're ending up often with devascularized or a potentially devascularized situation. This is a solid variant aneurysmal bone cyst. You can see the big soft tissue component that requires extensive decompression of the spinal cord. Here's the canal involvement. But having multimodality monitoring. By multimodality monitoring, we're talking about the SSCPs, which is the bottom-up monitoring, and then the transcranial motor evoke, where that's the top-down, where you're having a stimulation of the cerebral motor cortex and then recording that distally. Those techniques are very, very helpful for high-risk patients. Here's another high-risk case, a patient who presented with these changes. So to do this type of surgery, you really need this multimodality monitoring. In addition, free-running EMGs. So the SRS found that in 2000, the greatest concern on the part of the parents and the patients, and I would argue also the treating surgeon, is the concern for neurologic injury. The 2004 SRS report showed neurologic deficits at about 1%, and that had increased from the previous assessment done within the SRS in 1975, showing a 0.72. And I think all of us would hypothesize that perhaps the risk of neurologic injury is even higher now with these aggressive techniques. We'll talk about osteotomies, coupled derotation. Historically, there's been an evolution from just a wake-up test only to the use of SSEPs with or without a wake-up test. I think most everyone in North America now is using this multimodality monitoring with transcranial motor evoked potential monitoring, and there are some new techniques on the horizon that we may have time to discuss later. In our region, we began using transcranial motor evoked monitoring several years ago. There was concern that it could be harmful to the patient, that you can have burns or induction of seizures, tongue bite injuries. So the first study we did was a safety study just showing that it is safe to do this. There were no complications, no injuries caused by the delivery of this fairly high voltage dose of electricity to the motor cortex. It's really on the order of magnitude of ECT, or electroconvulsive shock therapy, used for psychiatric patients for bipolar disorders. It's a lot of voltage that's delivered. The site of mediation for these motor evoked potentials is the corticospinal tract, and technically you have to be very careful with your anesthesia and use TIVA, or total intravenous anesthesia, avoiding inhalation gas anesthetics. Those will suppress the readings. So you not only need the monitoring people and their equipment to do the monitoring, but good anesthesia to make sure that it can be done in a reliable way. And so this study showed that neuromonitoring using transcranial is safe and effective. There were no monitoring complications. Importantly, no false negative results. There was some concern early on that this led to false positive results, that there were alerts and surgeons would remove screws or back off unnecessarily. I think most of us now who have experience with this technique believe that it's no more a false positive than a low blood pressure is a false positive. It's really an assessment of the physiology, the blood supply of the spinal cord. And if you start to lose signals, it's just an early warning that you're starting to get into a situation that could have irreversible change. The second study that we did looked at a comparison of transcranials with just SSEPs alone, and at that point in the United States and North America, there were still quite a few centers just using SSEP alone, and the hypothesis was that SSEP alone missed many cases and was later in showing changes as compared with the transcranial motor evoked, and that both the SSEPs and the wake-up tests were too little too late, and that the addition of the transcranial motor evoked allowed you to be able to find out about an impending vascular compromise earlier. So this was 1,100 patients from 4 centers. There was a standardized protocol at that point. We developed a protocol for this TIVA, or total intravenous anesthetic, no paralytic agents, controlled hypotension during exposure, and then raising the mean arterial pressure during the correction. And essentially, to make a long story short, what we found, there were no false negatives. Every neurologic change was detected. There were some. These are the operating characteristics for the transcranial motor evoked, and you can see that there were no false negatives and no false positives. All of the deficits, all 9 patients who had either transient or permanent deficits from these 4 centers were picked up, and those who had no problems with monitoring. But this is the slide to remember. This is the test operating characteristics for the SSEPs. If you use SSEPs alone in this series of 1,100 patients, 4 of those patients had motor deficits but had normal SSEPs. So if you're using SSEPs, you will miss certain cases of neurologic injury. And importantly, I'll skip through this, importantly, the changes when they occur occur much earlier with the transcranial motor evoked monitoring. And this is just an example of a patient with no SSEP changes despite a complete motor loss in the right lower extremity. And then the final conclusion was that the transcranial motor evoked changes occurred more rapidly. And here you can see a 9-minute delay in the appearance of the SSEP changes, and those changes were picked up on transcranial motor evoked monitoring 9 minutes earlier. So these are the conclusions. So the evolution of monitoring in Philadelphia, and I think really North America now, is that this multi-modality monitoring has been adopted. We're in the process of trying to publish a surgical response algorithm. The bottom line there is if you see a transcranial motor evoked change, back off from what you're doing. If you're correcting, back off, loosen, relax, raise the blood pressure, importantly transfuse, make sure the patients are warm enough, correct any metabolic abnormality. And generally those changes will improve and return to normal, and then you can proceed with the surgery. In my experience, I've had several cases, many cases with intraoperative decrease or temporary loss of transcranial motor evoked potential, and these are not false positives. I think they're true positives, and we respond by raising the blood pressure, providing packed cells, backing off and correcting forces. I've had 3 cases in 23 years with a complete loss of transcranial motor evoked potential monitoring. And on those patients, you remove the rods. We know that the screws are okay from the O-arm scanning. We remove the rods, however, close the wound, leave the operating room, administer steroids. Fortunately, all 3 of those patients have recovered completely within 3 to 4 days after the surgery. We returned to surgery 1 week later and re-instrument. All 3 of those patients were successfully re-instrumented 1 week later and did well. So it's best to live to fight another day, but if you see it coming early and back off, it's better than persisting or missing the impending spinal cord injury. There have been none with permanent deficit. We have had 1 permanent deficit at our institution. That was a child with a syndromic condition where when the child laid down on the table and went to sleep, lost signals even before positioning. And I think there are several of us in the SRS who have a case or know of a case where if you lose transcranial motor evoked potential monitoring with just positioning, the chances of that child ending up as a paraplegic spinal cord injury are very high, and it's probably best to think very carefully about whether to proceed with that surgery. So in summary, this is a team sport. A surgical team has to watch and know about anesthesia and monitoring, and those other 2 groups have to know what we're doing. What is the standard of care in your part of the world? I would strongly encourage those of you not using transcranial motor evoked potential monitoring to add that to your practice. It's not expensive. The training is available. We won't ask for a show of hands. I think in North America this has changed considerably in the last 10 years, but consider transcranial motor evoked monitoring if you're not doing it now. Just a word about osteotomies. I think most of us in North America are using Ponte osteotomies for deformity correction. And this is the line of progression that I would recommend. You don't want to start with the vertebral column resection, never having done the other osteotomies. Get comfortable with Pontes. Try a lumbar hemivertebrectomy patient. Work with a senior colleague. Then higher hemivertebrectomies. Pedicle subtraction osteotomy is needed more often in the adult deformity setting, occasionally in the pediatric setting. And then vertebral column resection is a very controversial area. I've done 5 or 6. I'm very worried and nervous when I'm doing a vertebral column resection. Once you cross that bridge, once you've removed that bone, there's no going back, and there is risk with that. I think what most of us are doing for deformity correction is really not a Smith-Peterson osteotomy. The Smith-Peterson osteotomy is, as originally described, it was a revision single-level chevron osteotomy that was an acute anterior opening wedge. What we're doing is really more of a Ponte osteotomy, which, as originally described, was a primary multiple-level osteotomy to restore kyphosis or lordosis or just free up the spine. In my practice, I'm doing Pontes pretty much for most of the deformity cases, and especially to help with sagittal plane alignment. And here's a case, again, just with a stiff, rigid curve with Ponte osteotomies and coupled derotation, you can get a good result. And here's a case of a vertebrectomy. Again, this is in a lumbar spine where spinal cord monitoring is very important, but also direct nerve root stimulation. We're paying attention to the EMGs at this level. And so with these osteotomies, pedicle subtraction osteotomies, you can get great corrections. Here's this the same patient with restoration of sagittal curvature. Here's another vertebrectomy VCR patient with correction of lumbar spine. And then hemivertebrectomy is rather straightforward. And finally, working in the lumbar spine for high-grade spondylolisthesis, again, very, very important to have good monitoring. I think I'll stop at that point and entertain questions. Thank you.
Thank you very much. Now it's open for questions. Again, please come to the microphone.
John, thank you very much for this lovely lecture. We just started doing surgeon monitor